Hi everyone, and welcome to the next set of slides screencasting. As you remember in our conversation I had about the study guide and your responsibilities, I will not be formally teaching the muscles, but you will be studying them and learning them on your own, and I will be supporting you through this kind of situation, as well as some work in the classroom and evaluations. So this first set of slides, as you can see, is all the muscles that are related to the skull and face. A couple things I'd recommend before you get started would be first to pull out your Musculino muscle manual, and secondly to pull out the study guide that shows the pages for each of these muscles and where you can find them. I would further suggest that you print off that chart that's on page 3 of the study guide to start filling it in with the structures as I go through. I would recommend that you do a muscle, pause it, write down as much information as you can, maybe study some of the book or textbooks that we have in relation to it, and move on to the next muscle. In week 4, there is an anatomy test to be done. That anatomy test will be pretty much solely related to the muscles that you're doing here in this slide set and the next one to follow. So the first slide set, as you see, is the muscles related to the skull and face. The second slide set is muscles related to facial expression. Okay, and let's move onward. So as you can see here in the diagrams, we're talking about all the muscles that are related to the head and face, and you can see there are quite a number of them. And a few of them we're not taking. They're small. They're obviously important to certain things that occur in the face. But from a perspective of what we're doing, I won't be doing all the muscles per se, just the ones that are listed here. So the first muscle is called temporalis. And when we talk in class about how muscles are named, this muscle is named because of where it's found. And it is found in what's called the temporal fossa. We will be taking this when we discuss the skull in class next week, so you'll get a sense of where it is, and I'll kind of mention it in relationship to this muscle. So this muscle proximally attaches to the entire temporal fossa, except the portion of something called the zygomatic bone. From there, it goes to components of the mandible, which is the bone that moves at the lower jaw, and that is called the coronoid process and the ramus of the mandible. What's important to understand is that in this course we have to get a little more in depth to that. So within the context of this coronoid process and ramus of the mandible, it also includes the anterior border, the apex or the top, the posterior border, and the internal surface of that coronoid process, as well as the anterior border of what's called the ramus. So that is a relatively significant distal attachment at the lower parts. Its function its primary function is to elevate the mandible at the temporal mandibular joint. Again, we will be taking that in class next week, but just think of it as the joint of the jaw. Occasionally on my slides, if a muscle does a number of actions, and that you see that I have in brackets primary, that means that its primary action is that one, and the rest are all synergist to other muscles. So, number 1, it elevates the mandible at the temporal mandibular joint. That's its primary action. And number 2, it retracts the mandible at the TMJ. I have a video coming up about jaw retraction. You'll be able to see it a little more as I go through it. Now, when we look at this muscle, it's relatively square. I'm going to jump ahead here just for a moment, and you'll see at the bottom here its attachments, and you'll see that as it spreads out through this entire area, the muscle fibers are relatively altered in terms of their relationship to the attachment. One of the key things I can speak to now is that we look at the fact that a muscle moves a joint on its axis, and it is the direction of the fibers in relationship to where it crosses the joint that causes the joint to move in a particular way. So if I go back, we see here that the anterior fibers elevate the mandible. Elevating the mandible is closing the mouth. Okay? Closing the mouth. the posterior fibers retract the mandible. In other words, they pull the mandible back in this direction. So again, if we go the, oops, I'm sorry, I went the wrong way there. The anterior fibers elevate the mandible, the posterior fibers retract, and the middle fiber does both. So we see here the anterior fibers pull the jaw up in closing, elevation, and the posterior fibers back here, you see the direction of the fibers and the vector of angle of action they'll do. They will pull the mandible back, thus pulling it back posteriorly, which we know as retraction. It's innervation, so that's the other thing that you're going to have to key in on with studying this material. I know you don't know the nervous system at this point, but suffice to say that, as I spoke of in class, every muscle has an artery that enters it and a nerve that enters it. So what we look at when we're looking at a muscle's innervation, we take it back to the origin of that nerve, and it's named accordingly. When it comes to the muscles of the head, they generally tend to be nerves that are called cranial nerves. Cranial nerves are called cranial nerves because they originate from the cranium. Whereas all other nerves originate from the spinal column, they are known as spinal nerves. There are 12 cranial nerves, and they are represented in Roman numerals. So we see here on the right-hand side, innervation for temporalis is the trigeminal nerve. It's cranial nerve 5, and it is the deep temporal branches that innervate it. The trigeminal nerve exits out the side of the head, and it has 3 branches, hence its name trigeminal nerve. But for now, all you need to know is this. So we see here in the diagram, here is the muscle, its relationship to the coronoid process and the ramus, where its attachment is. You see it in here as well. You'll note also that the central part of the temporalis muscle is a lot of tendon, which allows for attachment. So think of the muscle attaching onto the bone here, around the temporal region, and then it becomes more tendinous as it gets closer to its distal attachment here at the coronoid process and the other parts of its attachment. Okay? So, the next muscle I want to talk about is called masseter. It has a deep layer and a superficial layer. The superficial layer attaches from the inferior margins of the zygomatic bone and the zygomatic arch. This would be the superior attachment, I guess you could kind of call it the proximal attachment, to the angle and inferior 1/2 of the external surface of the ramus of the mandible. Its deep layer is from the inferior margin and the deep surface of the zygomatic arch to the external surface of the coronoid process and the superior 1/2 of the external surface of the ramus of the mandible. So you can see that generally its distal attachment is slightly different, but not so much. So we see superior 1/2 of the external surface, superior 1/2 of the external surface of the ramus for the deep layer, and the angle is a little more involved in the superficial. But ultimately, what it does, and we'll show here in the picture, what it does is actually is a relatively square muscle. We find its attachments here around the zygomatic bone and the zygomatic arch. This is the superficial layer that you see here. This is the deep layer. This may be a little bit better diagram here. We see the superficial layer here on the left. The superficial layer has been removed in the next diagram, and we see the deep layer that lies underneath it. So, its functions is to elevate the mandible at the TMJ. That is the temporal mandibular joint. That is its primary function. So it is a major closer of the mouth, which is elevation. It also provides protraction, pulling the mandible back, pulling the mandible forward, and retraction, which is pulling the mandible back. Its innervation, again, is the trigeminal nerve, cranial nerve 5, the anterior trunk. I'm not going to get that caught up in the trunks. I just want you to know the major muscles, in most cases here, which would be the trigeminal nerve for the first 2 muscles. So again, we see here the masseter relatively square or rectangular. there is a superficial head and its attachments, and then we have a much deeper head here. The next muscle is something called the lateral pterygoid. It finds attachments to the sphenoid bone, and then goes down into the mandible and the temporomandibular joint itself as well. And it's not really down, it's actually kind of forward. So you might say that the sphenoid bone would be the proximal attachment, and the mandible and TMJ would be the distal attachment. There are two heads to this muscle, as we can see here. So at the top we have a superior head, an inferior head, and this is the sphenoid muscle here, and the TMJ back here. So the superior head is the greater wing of the sphenoid, which is a bone of the skull, to the capsule and the articular disc of the TMJ. So when I discuss the TMJ in class, you'll see that there's actually a meniscus in there and a capsule that surrounds it, because it is a synovial joint. When this muscle contracts, it actually pulls on the disc and pulls on the capsule. I'll explain that much further when I discuss the temporomandibular joint. But for now, just understand that it does have an effect on that disc, on the capsule, the superior head. The inferior head is on the lateral surface of the lateral pterygoid plate of the pterygoid process of the sphenoid. It is a small area on the sphenoid this is attached to, and it goes to the neck of the mandible. So we see here that here is the neck of the mandible, the inferior head at the bottom here. And we see that the superior head attaches to the joint capsule, and also some fibers attached to the articular meniscus or disc that we see here. Its functions has two major functions. It protracts the mandible at the TMJ, so pushing it forward. It also contralaterally deviates the mandible at the TMJ. I'm sorry that the pterygoid nerve should be over here. I don't know how I missed that. I'll try to fix that when I put the slide back into the banner. But so first function is it protracts the mandible of the TMJ, and the second is it contralaterally deviates the mandible of the TMJ. Its innervation is the trigeminal nerve, cranial nerve 5, the lateral pterygoid nerve. So what exactly is lateral deviation? When we talk about lateral deviation, it is the jaw moving side to side. If we say that a muscle is a contralateral deviator of the jaw, contralateral meaning the opposite side, it means that if the right muscle contracts, the jaw will move left, or if the left muscle contracts, the jaw will move right. So what happens when there's lateral deviation? Well, the jaw moves anterior, inferior, and lateral in a glide of the mandibular head and the disc. So we are talking about the mandible here that's doing the movement, which is the lower bone of the jaw. I'll repeat. The mandible moves anterior, inferior, and there's a lateral glide of the mandibular head and the disc. Ipsilateral deviation is when it is on the same side. So a muscle on the right moves the mandible of the jaw to the right, the same side. When that happens, we get a posterior, superior, and medial glide of the mandibular head and disc. So let's go back here just for a moment. We say here that the lateral pterygoid is a contralateral deviator, so it contralaterally deviates the mandible at TMJ. That means that if the left lateral pterygoid contracts, the jaw or the mandible will move to the right. If the right lateral pterygoid contracts, the jaw will move to the left. So what I would like to show you here is I have actually done a video of myself. We'll watch it and then we'll talk about it a bit. So I just want you to observe my jaw movements as I'm moving it side to side. Oh, sorry guys, I don't know what happened there. So if we go back to the beginning again, if my jaw is moving to the left, which it's doing here, it's deviating to the left, that would mean that the right lateral pterygoid up in here is contracting, which is causing that to happen. Okay? Conversely, when I move to the other side, it is this lateral pterygoid that is contracting, that's moving the jaw to this side. So left moving the jaw right, and right moving left. I'll just pull it up here just ahead a little bit. So you can see that when I'm moving in this direction, there is some movement that's occurring here on this side. So if we go contralateral movement, so this right pterygoid is contracting, my jaw is moving left. Let's go back to the movements. So if it's a contralateral, that means that the mandible has moved anterior inferior, and there is a lateral glide of the mandibular head and disc. So again, I'll go back to that. Maybe you can see it here that when it moves side to side, when the jaw moves this way, this side of the mandible moves anteriorly, but we'll spin it around so we can see it from the side. You will note that when I move forward, or when I move to the side, so we can see it here because we're on the right hand side, when the jaw went left, you could see some movement here under the cheek where the mandible was actually coming anteriorly to cause that deviation to occur. The second thing that we've seen a couple of these muscles do is protract and retract. So protraction is the extending of the jaw or tongue forward, in other words, pushing it out. And the adjective we use when we look at it, we could say that the jaw is protracted. Retraction is the exact opposite of that. We're bringing the jaw or the tongue backward or in, and the adjective for that, if we're looking at a jaw, is we're saying that it is retracted. So we will watch here the movement. My jaw, that is protraction and retraction. That's retraction, protraction, retraction, protraction. Okay? Let's do it again. It's a little bit quick. So that's retraction. The mandible has moved backwards so that the lower teeth are behind the front. And then forward is that we have this is protraction. The lower teeth are ahead of the upper teeth in the movement. Okay? So I just thought I'd show you those so that when we're talking about deviation and or protraction and retraction, you have a sense of what that means. All right, we did the lateral pterygoid, and now we have a medial pterygoid. Suffice to say, if just from the perspective of their names, the lateral pterygoid sits laterally to the medial pterygoid. So the lateral pterygoid is a little more superficial. The medial pterygoid is a little deeper. So its attachments, it has two heads as well. It has a deep head and a superficial head. Its attachments are to the sphenoid bone. So the deep head is on the medial surface of the lateral pterygoid plate of the pterygoid process of the sphenoid. Something called the palatine bone, which is the hard bone that makes up your hard palate, up above your tongue there, and the tuberosity of the maxilla. The superficial head arises from the palatine bone and the maxilla. Both heads go to the internal surface of the mandible at the angle and the inferior border of the ramus of the mandible. So we'll have a look at it here. This is a coronal or frontal cut. We're looking behind the jaw. So we can see here we have the lateral pterygoid kind of at the lateral aspect that we just talked about a moment ago. This is the medial pterygoid here. So it is here is the plate of the sphenoid here that we're talking about that it attaches to, and then we find its attachment on the inside of the mandible here. If we look here on the right hand side, the medial pterygoid sits in behind the jaw. Here at the mandible, it's on the inside part, whereas the lateral pterygoid is more superficial because it's outside onto the areas here. Its functions, it elevates the mandible at the TMJ, so remember elevation is closing, so it is also a closer. It protracts the mandible at the TMJ, so it sticks it out. And it is also a contralateral deviator when it's working unilaterally. So both 1 and 2 are when the muscle works bilaterally. In other words, when both sides, both left and right medial pterygoids are working, it can elevate the mandible at the TMJ, and it can also protract the mandible different fibers. When it works alone, so when the right one works alone or the left one works alone, they are contralateral deviators. So the right medial pterygoid contracts and the jaw deviates to the left. The left medial pterygoid contracts and the jaw deviates to the right. The innervation here is again the trigeminal nerve, cranial nerve 5, and it is the mandibular division. So we see it here. You can see why it deviates to the opposite side. This attachment distally here on the inside of the mandible is going to move towards this more fixated part here up in the sphenoid. Hence, then, if this part is moving closer to this part, then the jaw is going to move in this direction. The next is the hyoid bone. Actually, I'm going to go back just for a moment and explain that all these muscles that we've talked about in regards to temporalis here, we've got masseter here, we've got lateral pterygoid here, and we have medial pterygoid here. All these muscles are extremely important because they are related to a condition called temporomandibular joint syndrome. In massage therapy, we treat this extraorally and intraorally. So as in the coming semesters, you will learn how to work inside the mouth to palpate some of these muscles and massage them to get tension and tone out of them. And you will also be able to work outside the jaw to work on a couple of these muscles as well. So these muscles are vitally important because they are very much related to temporomandibular joint syndrome. So moving away from those muscles that are directly related to the TMJ, I want to move to some muscles that can involve some influence on the temporomandibular joint, as well as some movements in and around the anterior neck. But although we haven't taken this in class and will next week, I think I want to talk a little bit about a particular bone that floats in the anterior part of the neck, and that bone is called the hyoid bone. It sits in the anterior neck at about the C3 level. There is no direct articulation with bone, another bone with this bone. It's not like a normal jointed bone where we see two together, which results in it being extremely mobile. It is suspended by muscles that connect it to the mandible. The styloid processes, which we'll be learning in class, that's a relatively long, very narrow. It's called styloid because it looks like the styloid of a pen or a pencil. The thyroid cartilage of the larynx, the manubrium of the sternum, and the scapula. So although the hyoid bone floats in the anterior neck, through lots of muscles and ligaments, it actually is held in place by these. It is bound to the thyroid cartilage behind it posteriorly. There are some connections there which give it a little bit of stability. Muscles that originate above it are called suprahyoid muscles, and those that originate below are called infrahyoid muscles. So let's do the suprahyoids first. Your first suprahyoid is called digastric. There are two bellies to it. There is an anterior and a posterior belly. The posterior belly arises from the temporal bone, from the mastoid notch of the temporal bone, and travels down to the hyoid, with the central tendon being bound to the hyoid bone at the body and the greater cornu. There are some projections that come out of the hyoid bone, and someone feels they look a bit like a horn. So cornu is a direct interpretation of the word horn. That's the posterior belly. The anterior belly is from the mandible on the inner surface of the inferior border. It is known as the digastric fossa, but I wouldn't be asking a question on that. So from the inner surface of the inferior border of the mandible, it goes to the hyoid via the central tendon at the body and the greater cornu as well. It has two primary functions. First, it depresses the mandible at the TMJs. Depression is a mouth opening. So this helps open the mouth. And the other primary action is it flexes the head and neck at the spinal joints. So by fixating the mandible, it actually helps pull your head down towards your chest. A minor one that it does is it retracts the mandible at the TMJs. It also does, to some degree, extend the head at something called the atlanto-occipital joint, and that is the articulation between C1 and the head. It does have a reverse mover action. So 1 through 4 are its normal actions, but if we fixate all those things like the TMJ, the mandible, and the spine, it actually elevates the hyoid bone in the other direction. Its innervation is the trigeminal nerve, cranial nerve 5, and the facial nerve. I do have some pictures of that in the next slide set. The anterior belly is innervated by the myohyoid branch, and the posterior belly is innervated by the facial nerve. And I'm being a bit picky about this one just because it has the 2 separate innervations. So we can see it here in the diagram, right? So we're talking about the digastric. So here is digastric here. So you can see when I talk about that it has a posterior belly and an anterior belly with a tendon here. Here's the posterior belly of digastric. We have a central tendon here that is attaching to the hyoid bone, and then we have the anterior belly of digastric here. If we turn the head over to the side, this is a nice drawing here, we see the posterior belly of the digastric here, up in the mastoid fossa where it attaches. As it comes down, there is a central tendon right here, here to here, with the anterior belly here. So it's almost like a bit of a tendon with a loop that we can see here that helps attach that digastric from the skull down to the hyoid, and from the hyoid up to the posterior aspects of the mandible. The next is called the Milo-hyoid. Again, we're still staying with the suprahyoids. Its one attachment is the inner surface of the mandible to the anterior surface of the body of the hyoid bone. Again, traveling down. So you could say that the inner surface of the mandible would be the proximal component, and the anterior surface of the hyoid would be the distal. Its functions both are primary. It depresses the mandible at the TMJs. Remember, depression is opening. And it flexes the head and neck at the spinal joints. So if the mandible is fixated, it brings the chin down towards the chest. And much like the other muscle, if the mandible stays fixed and the neck stays fixed, then its reverse mover action is to elevate the hyoid bone. It is also innervated by the trigeminal nerve, cranial nerve 5, and it is innervated by the myohyoid branch. So we see here the myohyoid muscle is a much thicker kind of muscle. So this is an anterior view from the posterior aspect. The skull has been removed. We're looking at the mandible kind of sitting by itself with the hyoid bone floating down below. So this is the geniohyoid. We won't talk much about that one, but you'll see it's a fairly broad, thick muscle. Looks much better in this view. So here's the digastric muscle that we talked about. This is the anterior belly and the posterior belly here. We see this thick muscle underneath here kind of covers almost the whole inside of the mandible at the chin. This is where we find the myohyoid muscle. So our next muscle is called geniohyoid. It is found superiorly at the inner surface of the mandible as well, and it goes to the anterior surface of the body of the hyoid. The body of the hyoid is the most anterior part of the hyoid. Think of the hyoid as kind of like a U shape with the inside part of the U facing back towards the neck, or the spine, sorry. Again, 2 primary movements. It does depress the mandible at the TMJs, so opening the mouth, and it does flex the head and neck at the spinal joint. So it brings the chin down towards the chest. If we fixate the TMJs and the spinal joints, its reverse motor action is to elevate the hyoid bone. Its innervation is a little bit different than the others. It is the hypoglossal nerve, which is cranial nerve 12, which is a branch of C1. So this is partly a cranial nerve and partly a spinal nerve. It's a bit unique. So something to remember that it's a bit different. So there is a cranial nerve innervation and a spinal nerve innervation for this muscle. So we see it here. The genioid is 2 bands that run all the way up to the inside anterior part of the mandible here, and runs anterior to the myohyoid muscle, which we just took. Much nicer picture here. Digastric, so if we think about it, the digastric was the first one we took. Right, remember it has a posterior head and an anterior head, And so it loops around here with a central tendon attachment to the hyoid bone back here. So we have digastric that runs up here. Then we would have the geniohyoid, which runs here beside it. And underneath both of them would run the milohyoid, which we've just taken. So geniohyoid goes right up from the main body, the anterior body of the hyoid bone, and goes right in and attaches to the back part of the mandible here at the most anterior portion. The next is the stylohyoid. It attaches superiorly from the styloid process of the temporal bone to the junction of the body and the greater cornu of the hyoid bone. So body is at the front, and the greater cornu, or the greater horn, sits a little bit further back. Its functions basically is to elevate the hyoid bone. If we occasionally look at it, it's a very minor mover with extension of the head at the atlanto-occipital joint. Do remember that the atlanto-occipital joint is the joint between C1 and the occiput, or the skull. It has a bit of a different innervation as well. Now we're into the facial nerve, cranial nerve 7. So we see it here. This is what I was talking about. The reason it's called the styloid process is because it almost looks like a pen. So this is coming from the temporal bone here, coming down, and we see the stylohyoid has its attachment here on the stylus, or the styloid process, comes all the way down to this part of the hyoid bone, here being the body, and the greater horn's kind of in behind all this soft tissue. So the stylohyoid comes down this way. Really nice diagram here. We see the digastric anterior and posterior bellies here in green. We see the milohyoid here from the inside of the mandible down to the anterior body of the hyoid bone here in red. And then we see the stylohyoid rising from the styloid process here, going down to this midpoint of the hyoid bone here. That concludes the suprahyoids. Now we're going to move on to the infrahyoids. Okay, infrahyoids. The first is called the sternohyoid. So you should be getting a pretty clear picture now that all these muscles are named according to their attachments. They're all named generally from the areas that they arise from and go to. So your infrahyoids, remember, are below the hyoid bone, where all the previous muscles have been above. So the sternohyoid arises from the posterior surface of both the manubrium of the sternum and the medial clavicle, and go up to the inferior surface of the body of the hyoid bone. Remember that the body is the anterior part of the hyoid bone. Its main functions is to press the hyoid bone, so pulling the hyoid bone down. It also is a minor flexor of the neck and head at the spinal joint, so it too also pulls the chin down towards the chest. In reverse motor action, if we fixate the hyoid bone and the head and neck, it does help elevate the sternum, which usually happens to some degree when we take a big breath. It's certainly not a primary mover of the rising of the sternum, but it does somewhat assist in a synergistic point of view. Its innervation now, because we're so low, it's now leaving the spinal nerves and heading into what's called the cervical plexus, C1, C3. So what does that mean when you see in brackets C1, C3? When we take the spine, we'll understand that there is a foramen when we look at the stacked spinal bones, or the spine bones of the C-spine and the T-spine and the L-spine. There's a foramen there, and that foramen is where nerves either enter into the spinal cord or exit the spinal cord. So when we're talking about innervation, we're talking about motor innervation. So these would be nerves that are leaving the spinal column. And what we're saying here is that sternohyoid is innervated by branches of nerves that arise from the C1 level and some nerves that arise from the C3 level. There's no nerve innervation from the C2 level. So cervical plexus, C1 and C3 innervate sternohyoid. So we see it here. Here's sternohyoid here. We said up into the body, inferior part of the body of the hyoid bone, and part of the medial clavicle and the manubrium of the sternum. We also see it here in this picture with all the other muscles we've kind of been looking at. This is the sternohyoid here, again, from the manubrium and the clavicle, rises up here into the inferior part of the hyoid bone. Again, just as a reminder, here we see our posterior and anterior digastric muscles. Here we've got our Milo-hyoid that we talked about. Here we have our geniohyoid that we talked about, and our stylohyoid. I picked this picture because it kind of shows everything for you and the continuing muscles that we're going to do in the infrahyoids. The next is the sternothyroid. The reason why this is called the thyroid is because it attaches to part of the larynx. It is the only hyoid muscle that does not attach to the hyoid bone. So that's a key thing to remember about the sternothyroid. And you'll notice right in the name, it doesn't even use the name hyoid within its own name. Its attachments are the posterior surface of both the manubrium of the sternum and the cartilage of the first rib. So the previous muscle arose from parts of the clavicle and the manubrium. The sternothyroid arises from the manubrium and the cartilage of the first rib. It goes up to the thyroid cartilage of the larynx. Its functions, it helps depress the thyroid cartilage, which is what happens when we swallow, when we're eating food or swallowing water. And number two, it flexes the head and neck at the spinal joints, again bringing the chin down to the chest. And what we've been hearing sort of throughout here, if we inhibit the thyroid movement of the thyroid cartilage and the spinal joints, its reverse motor function is to elevate the sternum itself, sometimes done again when we're taking a big breath in. It too is innervated by cervical plexus C1 and C3. So we see it here in the diagram. This is the thyroid cartilage here of the larynx, kind of poking through. We see it here as well in this diagram. The sternothyroid, again, down from the first rib. Okay, here's the clavicle, here's the cartilage of the first rib. So it arises here from the first rib and goes up and attaches here at the thyroid cartilage. There is no attachment here to the hyoid bone. In this diagram as well, we see it. It is not showing it as attachment to the cartilage of the first rib. The first rib's kind of been removed, but you'll note here in this diagram, this first rib does lie just underneath the clavicle. So there's an attachment here and rises up to and attaches to the thyroid cartilage here. So we're kind of seeing it here behind, and it is the sternothyroid is here. So a couple of differences which I talked about. Remember, the sternothyroid attaches to the sternum and the cartilage of the first rib to the thyroid cartilage here. So we see the muscle belly here. And then the sternothyroid, hyoid, which we talked about, arises from the cartilage of the clavicle joint, sternoclavicular joint, and the sternum to rise up here to the inferior surface of the body of the hyoid bone. The next infrahyoid is the omohyoid. Its inferior belly and superior belly are separated. We have the inferior belly attaching to the superior border of the scapula. It might be a bit of a shock to some of you. Now we're back to the scapula. To the clavicle via the central tendon, where the superior belly goes from the central tendon at the clavicle to the inferior surface of the body of the hyoid. So what's happening here is this muscle is arising from the superior border of the scapula and traveling to the clavicle where there is a central tendon. That tendon, so think of that tendon as being the attachment of the inferior belly. It then makes a bit of a loop and heads up, and the superior belly attaches to that central tendon now and arises from that central tendon of the clavicle to the inferior surface of the body of the hyoid. We'll see that in a moment in the picture. Its two functions are to depress the hyoid bone, pulling it down, and secondly, like the previous muscle, it also flexes the neck and head at the spinal joints, bringing, again, the chin towards the chest. In reverse motor function, so when we inhibit its depressing of the hyoid bone and fixate the head and the neck, it actually helps elevate the scapula at the scapulothoracic joint. The scapulothoracic joint is a bit of a misnomer, but it is the area where the scapula and the thorax, the rib cage, kind of come close together. You'll learn a lot more about that in clinical anatomy too. Its innervation, again, very similar to when we've been talking about. It arises from the cervical plexus of C1 to C3. So the previous two muscles were C1 and C3. This muscle is innervated by C1 branches from the C1 level, the C2 level, and the C3 level. So if we go back here to the omohyoid, you will see that this is traveling forward back from the scapula to this central tendon, and the superior belly is from this central tendon and arises up into the inferior border of the hyoid bone. Again, I'll repeat. Okay, we see here in this picture, this posterior belly of the omohyoid is attached here on the scapula to the central tendon, and then the anterior belly of the omohyoid comes up here to the hyoid bone. This kind of has a great shot at the scapular attachment of the muscle, and this drawing over here shows a lovely attachment to the central tendon to the hyoid bone. Kind of misses it out here, but between the two you get the gist of it. There's this central tendon, posterior belly, scapula to central tendon, superior belly or anterior belly, depending on the author, from the central tendon to the inferior surface of the hyoid bone. Thank you, and that ends the set of slides for the muscles of the head and the hyoid bones. The next set of slides will be dealing with muscles of expression.